Welcome. We're going to go ahead and get started. Thank y'all for coming on this rainy Tuesday afternoon. My name is Meredith Fitzgerald, and I'm the director of the Clinical Research Support Program. And we've got a really good agenda today. I'm going to give you some save the dates. Research orientation will start again in January on the 30th and in March. If you have any new employees, if you'll please register at the CRIS training at uabmc.edu, we'll help you get your new employee registered. In January, we'll start again with our special topics in clinical trials. We have a really good first quarter. January 9th, Adam's going to kick us off with UAB IRB updates. Then we're going to have another update with ClinicalTrials.gov with Denise McKenzie. February 6th, Carrie Oliver and Dorothy are going to continue our program series that we're doing with filling out IRB forms. Expedited reviews, I believe, is on tap. On February 20th, we have recruitment and retention, research match, social media with Mark and Matt. And then on March 5th, Mark and I are going to do a continuing budget workshop with updates with the fee sheets. If you have any suggestions, we are always looking for topics. We want it to be something that you want. So please email us at any time. Encore Training. We have another Encore Training December 17th. Then we'll wait to the end of January, or mid-January, January 21st. Then February 25th. CITP, we are in the midst of revising the clinical investigator training program and kicking off some additional investigator training. So that will be probably in April 2020. The research program, training program will start again in the 6-week series on April 7th. So again, here's our email, so please feel free to ask us any questions about registration or questions about training or request. How to gain access. We did this last time and we got really good feedback. We've added some additional sites. So if you have any questions or need resources, there's some websites that you can get information. And then we're also kicking off in 2020 a kiosk with the CCTS on training. So we're really excited. We're going to post videos. So on your own time, you can watch. Some of them will be the special topics or research seminars, but then we'll do additional topics with OnCore and budget training. So please be looking out for that in the first quarter of 2020. OSP Updates. Debbie.
Good morning. Nice to see you guys on this wet, rainy morning. Just have a few updates for you guys. Thank you again for letting us come and give you some of our updates. Some of you guys already know about this. It's old news, but just in case you've been living under a rock the last few months, maybe you haven't heard, we're changing our submission process beginning in January. So January 1, we have some different submission requirements, and I'll go over the details in a minute. And a lot of you are clinical trials. This doesn't apply to you, but a lot of overlap is in this group. So just wanted to make sure you knew about that. Also, we have a new form on our website for processing awards. It's an internal budget form, and it's very easy to find, but I'll talk about that and show you what it looks like. Also, we have a new, I guess the old Research Digest is going away. We have a new, better looking newsletter, and I'll show you what it looks like. So that'll be coming out in January as well. So if you have items you want to put in the digest, it will now go into this new form, and I'll tell you what that looks like. And then also want to let you know about our upcoming Research Administration Forum. We have another one coming up in January. Thank you to everyone who came to our first one. It was great. We had a great turnout. It's right here in this room as well. So we'll have that again in January. So in case you're not familiar with the new requirements, starting January the 1st, your final proposals will be due into OSP 5 days before the sponsor deadline. The Ready Submit proposal will be due to OSP no later than lunch, noon, on the business day before the sponsor deadline. Also, make sure that you get an email confirmation to your OSP officer indicating that it's ready for submission, just like always. That's nothing new. And then for NIH submissions, remember to always include a screenshot and assist saying that everything is passed all your validations so we can know that you've put it through that already. Did I go to the next one? Yes. So PI submitting to NIH also need to review that application image. You know, you can review the entire application in Assist. That's the great benefit of using Assist. So be sure that they do that before you submit to OSP. Any change corrected proposals will be limited to technical and system related issues only, because you can already see that ahead of time. So that really saves you guys some time. Also, due to volume, we may not be able to resubmit a grant application due to PI changes that should have been caught during that particular time. So that's really nothing new, but just a reminder for you. In a rare instance, you might need to get an exception to this deadline process. We don't expect to see many of these, but if we do, the PI must submit a letter of request signed by the PI, the department chair, the dean. Send that to Chris Brown, the VPR, research, and indicate your mitigating circumstances. There cannot be any delegate or per-signatures accepted on that. And if approved by Chris Brown, approval should be included in your OSP submission as well, so we can see that you've had an exception granted. Any exceptions after noon, the day before the sponsor deadline, will not be considered. So let's say your application is due on Friday at 5, then that final is due Thursday at noon. Also, we have a new UAB internal federal budget form for processing of your awards. We used to use PHS 398, but it did not include enough details for the folks who process the awards in OSP to see the exceptions, that kind of thing, here exclusions, I'm sorry. So we created a new form. I say we, but I did not create it, so I'm not an expert on this form, but I know where to find it, and it's very easy to use. So it's on our website. You can get up to 6 subs on this form, and then if you have additional subs, you can just use additional forms. This is mandatory beginning January the 1st, and this is really just for internal use only. So this does not replace any sponsor required budget templates that you guys might be using. This is what the form looks like. It's very easy to find. It's under our form section on the website. So be sure to use that. And then also our research digest is going away, like I said, and we're getting a new newsletter form. It's going to be called Research Matters. It's going to be very similar to Research Digest as far as the way you submit items. So that'll be on our website, scheduled to go live January the 5th, and this is what it looks like. So you can agree with me that does a lot better than the Research Digest that you probably just don't even read anymore because it just looks the same, right? So we look forward to getting that out in January. And don't forget, our next forum, Research Administration Forum, is coming up January the 22nd. Rang is still working on some of the, agenda items, but it should be exciting. So we plan to see you here. Thank you. You want to move it?
Hello, everyone. Can you hear me? I understand you're eating. That's fine. I understand. My name is Cristina Blackman. I'm the new Education Outreach Specialist for the Office of the IRB. I'm here to present on behalf of Adam about some of our updates and things that we've been working on. Adam, our director. So what's happening in the IRB office? Adam mentioned in the last Lunch and Learn that we had 3 positions that were open. We're happy to report that those positions have been filled. The first is our Office Services Specialist, Malik Thomas. Malik is our customer service support for our front desk. He's been answering the phone calls and assisting you. So if you've called within the past month or so, you've probably interacted with him. He's been a great asset to the team, and we're happy to have him. The next is our Operations and Systems Analyst, which is Andrew Atkinson. Andrew is serving as our technical support for the OIRB website, as well as developing and managing our electronic resources. You may know Andrew's name from the past because he's a former protocol analyst too, and has experience with various types of protocol submissions. So we're grateful for his knowledge and are really excited about the projects that are coming down the line. The third position is our Education Outreach Specialist, which is me. My job is to develop and create new training and materials and resources for the OIRB. So I have 4 years of training experience, as well as experience in creating online courses and how-to videos. So our goal is to make everything easier for you with the IRB. And I'm excited to be here, and I welcome any suggestions that you may have regarding training. Next, we have our electronic resources. In our last presentation, Adam mentioned that our office had introduced personnel forms in the application process. These forms have helped us a great deal in terms of standardizing the information that we received from from studies regarding key personnel. We thank you for your patience regarding this change, and we ask that you continue to update this information if there are any changes for your personnel. Throughout next year, we plan to introduce additional electronic resources that we're excited about and we believe will aid in the IRB application process, both externally and internally. Next, we have the evaluation of metrics and baseline data. We mentioned before that we were working to obtain metric information to help us improve our processes, as well as appropriately allocate our staff and what their responsibilities. We have obtained that information, and we're going through the process of reviewing and evaluating it so we can assess what our needs are, as well as what our next steps would be. AHRQ reaccreditation. So we are in the midst of submitting our first step for the reaccreditation, the first step of the application. It will be submitted at the end of this week to meet the December 15th deadline. Once we submit the first step of the application, we'll be preparing for the second step in the spring. We'll be waiting for feedback from AHRQ regarding any changes that we need to make, but then we'll be preparing for an on-site visit in the fall. So additional information regarding that process will come later. Lastly, is regarding the single IRB. As you may know, single IRBs are used to review multiple sites that are conducting the same protocol instead of using multiple IRBs to review research at each individual site. So in January of 2018, the NIH instituted a policy requiring single IRB review for these multi-site studies that are being funded by the NIH. The revised Common Rule has mandated that all federally funded multi-site studies be required to use a single IRB starting January 20th of 2020. So the UAB Human Research Protections Program has developed guidelines for this and for UAB Single IRB review, and provides situations or scenarios in which UAB would serve as a single IRB. This information is located on the UAB IRB website. So if you go to uab.edu/IRB, you'll see on the right side, single IRB, and you'll be able to get information about the process and how your situation may fit and how CRBs may be processed. When reviewing this information, we ask that you consider how these changes may affect your study, particularly when it comes to budgeting for grants for any costs that may be associated with single IRBs. If you have questions regarding this, please consult the Office of the IRB, and we plan to send out additional communications soon. That's all that I have. Thank you.
Happy to welcome Matt. Matt's going to come tell us a little bit about himself. Thank you.
Well, I just scarfed down a roast beef sandwich, and now I see my name up on the front, and I'm up here to give a presentation. No, I'm not. Don't worry, you're not going to fall asleep today. My name's Matt Ronning. I am the new Research Integrity Officer. Many of you may remember Pam Vanellis. Dr. Vanellis retired, and she won't call me back. I keep trying. If anybody knows where Pam is, I'm trying to get in touch with her. No, I'm just kidding. I am, but I'm not. My role is a little bit broader than Research Integrity Officer. Many of you know that a Research Integrity Officer is a regulatory phrase, and it is defined by our research misconduct regulations. And I am happy to be the Research Integrity Officer for UAB. I have been a RIO, as we call them, for many years at many different institutions across the country. And it is not the fun part of being a research administrator. But I'm a really nice guy, and I like to have a lot of fun, so I do my best. This role at UAB, the Assistant Vice President for Responsible Research Practices, is broader insofar as we look much earlier, hopefully, and you will never meet me as the RIO, and you will meet me as somebody to help you solve some of your problems. And a variety of those are related to transparency in research, disclosures, working with your compliance offices, understanding your contracts. These are all handled by different offices, and the Assistant Vice President for Responsible Research Practices is charged with helping all of you together as you endeavor to manage your research and clinical trial projects. So I invite you to call me if I can be of any assistance to you whatsoever, other than to tell me some good jokes. That's always good as well. I don't have any to share. You will soon find. But if you do have any questions or concerns that I can help you with, I would love to hear from you and see you. I'm on the 7th floor of the administration building, but I'm not going to tell you the room number because I want you to push a bunch of buttons to find it. No. So feel free, look me up, and we'll go from there. I don't think I have a presentation. Okay, good. Thank you.
Thank you. And Mark is next.
Good morning, everyone. Yeah, still morning. So I just wanted to provide you all with some updates on some of the initiatives that we've been working on in the last, some of these couple of years. One of which, though, that you probably have heard from me or your administration about most recently is the career ladder. So as you know, when I spoke back in September, we were basically in the midst of the implementation. So at this point in time, we are wrapping up that implementation. You see here kind of where we kicked it off formally in terms of the organizations as we've gone through the 2019 calendar year, starting back with the Comprehensive Cancer Center in January, and then going through phase 1 and 2, all of which were in the School of Medicine through the summer. And then you'll see phase 3, we dipped out of the School of Medicine, got some of the other schools across campus, and then came back into the School of Medicine with the Department of Medicine in early fall, and then continued on with those last departments and one final school with nursing in late fall, and we are wrapping up those, a couple of those as we speak right now. So actually, those of you who are in neurology, you know that you got your REDCap assessment just this week, and so you'll be completing that this week, and then the administrators, as you know, will be finishing that up right before Christmas, and so then we will move on to that group, as well as we're right now in the midst of finishing our catch-up phase. So any of you who are new either to the organization as a whole or new to your organization because you came from another here on campus, you've been involved with us most recently because of our catch-up phase. And so we are working through that process as well. And as I said, the mapping of all of those individuals will be finished in January. And then we will be basically coming back to all the department leadership in late January and early February for our discussions about next steps relative to the implementation. We actually have been scheduling those meetings just this week. So some of you in the room probably got calendar invites from me this week in that regards. And so then we are slated for early 2020. I say that because we don't have the date firm yet, but right now we're looking sometime in the month of March to have our official go live date. So that's when people will be moving. If they mapped to one of the new titles in the ladder, that would be the date that they would go into effect. And then everything that goes along with that, as you've heard me talk about in our individual organizational meetings this year. And then so beyond that, really we'll just be using these new titles. There's 21 of them as a reminder. Going forward, we are working on internal processes within Central HR to talk about what the choosing of said titles will look like, since now it will be a little bit more complex than has been in the past. Of course, it depends on how you're defining complex, because as I mentioned back in the spring and the fall, we are basically reducing the titles across the clinical research ethos from 80 plus to 21 broadly. So obviously it's going to be less complicated from that sense, but then more so in the sense that right now, you know, if you just need, say, somebody that's a clinical research nurse coordinator, you have one from which to choose. Going forward, we're going to have 3 levels 1, 2, 3. So then it will be a determination of what level coordinator would you need in that role, what level of experience, education, et cetera. And so we're working through those processes to determine how we will help people identify what they need, as opposed to just doing what we've always done. And then in addition to that, we're also looking at some of our requirements around certification. This was something actually I've mentioned in some of these previous discussions in this venue as well. As you saw, when we've gone through the mapping process, that's been one of the things that we've been capturing to understand who do we already have on campus that's certified. I know that's kind of a moving target. People continue. I think I've seen people as recently as September or October of this year getting certified through one of the national organizations. And so we're looking at that in terms of what those requirements might look like, the timing of that, as well as at what levels would those requirements go into effect, as opposed to, say, a senior versus an entry-level role. So that's it relative to the career ladder. The other initiative we've been working on for the last several months has been the Greenphyre initiative. Hopefully, since you see there that we are now thankfully wrapping up wave 5, we should be finishing this up by the end of this calendar year. If not, it should be early 2020 when we finish this. But this has been something that you see there goes all the way back to 2017. Actually, some of the planning stages of this go all the way back to 2016. So some of you have been using it for quite some time. Overall, it's been going well for us. We get very few queries in terms of just people having issues. Most of that has centered around what few I'm aware of, and I think I can only recall 3 instances right now with the whole, can I get cash off my card without having to pay an ATM fee? If you continue to or ever encounter that with one of your participants, feel free to reach out to me directly. I'm always happy to reach out to specific bank branches just to make sure that they're aware of their requirements in terms of enabling people to get cash without having to pay an ATM fee directly from their MasterCard. By and large, it seems to not be having an issue, but occasionally we do run into that. And it generally falls into the category of a teller or somebody just needs some re-education around that ability. And so just as a reminder on this, this is a replacement means for paying participants in lieu of petty cash and prepaid Visa debit cards. I've already been in contact with Central Administration and Financial Affairs, as well as those of you who are in the School of Medicine, and talking with leadership there, and they are planning to basically be shutting down the use of petty cash and prepaid Visa debit cards in the research participant payment mechanism. So if you do have studies on which you're still paying them, we have been working through the process of getting those closed out, whether it be quickly versus through attrition, depending on how much time you have left on that study. So, but definitely, I've already been communicated to that they're not planning on continuing to approve that payment mechanism. So, and this is something that we've been trying to make sure that everybody's aware of across institutions the last couple of years. So none of this should really come as a surprise at this point in time. But if you have questions, feel free to reach out to me by phone or by email, and I'm happy to address those. Research summaries. So again, one of those things that's been around for a while. Mostly this is just a reminder to you guys that we are using clinical research study summaries in Cerner for those people who are being entered into OnCore, which John will be speaking about later. But this is one of those things where if the participant, once they're entered into OnCore, that sends a message over to Cerner, and then that entail would trigger the on-study Banner bar indicator for that participant in their EHR. And then this summary is supposed to be available for them to have this information point of care for the clinician who's treating them. My recommendation to people is and has always been that you make sure to go ahead and create this study summary at the time at which you're putting together your study submission, especially your regulatory submission, because generally it's the same information that you would be providing to the IRB anyway. It's typically one page, so it's pretty straightforward to create. By and large, you see there 5%. That's basically what I've seen over the last probably 4 to 5 months in terms of the number of outstanding summaries across the entire environment of study summaries that are needed. I think we're somewhere in the ballpark of 700 or 800 now that are in Cerner. And so only 5% of those is what we've routinely been seeing that were not having been created and entered. And so that's really just to say, great job. We're really excited about that. As long as we stay somewhere in that area, we are definitely happy. I always try to send out reminders to people each month. If you do have an outstanding summary that's needed, just to remind you guys to get that created and send that in to that email address, powertrials@uabmc. But yeah, if you just create those when you're creating a regulatory submission, then you probably just won't ever hear from you. So the other one is for pending accounts. So as you know, this is something that I actually probably spent a fair amount of time back in September talking to you guys about, and something that we've been communicating across UAB at large, especially with department chairs and executive administrators. So this is an initiative that, as you see now, has been almost in effect for 3 years. And really, we have seen pretty poor uptake of utilization of these pending accounts. And so basically what came down from us in late summer of this year from the President's Risk Cabinet was that for the units that were not utilizing those pending accounts as they were supposed to be, then they are going to start holding signatures of contracts with OSP until there's expenses allocated, and that expense should primarily, not exclusively, but primarily they're looking at effort, because that's our largest area of risk from a compliance perspective. So make sure within 45 days of your receipt of that pending account, for those of you who do manage these accounts, that you're applying the applicable effort, especially PI, but also staff, because that is something that we're starting in October of this year, monitoring on a month-to-month basis. And those holds are being submitted to OSP each month for any new pending accounts that fit the time period that they've been created after 45 days. But the applicable effort's not been applied yet. Those holds are applied. And then I just have to get notified by the award managers or someone within the department that effort has been put there. And then I go in and I verify in Oracle that it's there before releasing it with OSP for signature. The caveat for all of that is that word unless that you see there on bullet number 3, and that's unless you're using an operating account. So actually Simone Alexander from the Dean's Office, Director of Finance, she's going to be here in just a second to talk about the utilization of the operating accounts, because that's kind of new for several people around campus, which that does buy you some additional time. It doesn't prevent you or give you an exemption from using the pending account at all. It just gives you some additional time before that the actual expense is expected to be applied to the pending account. So with that, I'll turn it over to Simone.
Thank you, Mark. Well, I can officially say good afternoon now. It's 12:01. So hope everyone is doing well. Thank you for coming out today. So just want to give you a brief overview about clinical trial operating accounts. So primarily just to distinguish, to say what exactly is a clinical trial operating account. So this is an account that you can use to accumulate all of your indirect expenses or expenses that you're unsure how they should be allocated to the clinical trials. So you can pretty much park everything here, and then, well, some things you don't have to do it but quarterly, but we recommend that you go through and reconcile this account and move all the expenses out to the appropriate clinical trial account at least once a month. That's just going to keep everything kind of going, keep your effort going. And if you have an opportunity where you need to make any changes, then since you didn't kind of wait until that quarter, then it'll be a little bit easier for you to pick up on any necessary changes that you need to make. So the big question would be, do I need one? So in School of Medicine, we started running this in our newsletter back maybe like April timeframe for people to go out to LMS to take the test. to understand exactly what entails in a clinical trial operating account. Primarily, if you have a pretty large operation, you have many clinical trial accounts, many research coordinators, many research nurses. Oftentimes, this account is going to help you to manage that because you'll be able to go back and look at the actual activity on the account after things have happened, so you can decide what things should be moved from the clinical trial operating account out to the actual clinical trial account. So we've had quite a few of these set up within School of Medicine. So all of those required to come through School of Medicine and have those set up. But we do have some areas that have elected not to use the clinical trial operating account. And I would just say to ensure that you are separating up and appropriately charging your indirect costs out to all your clinical trials, since you don't kind of have this one account where you see those costs and it's constantly on your mind that they need to be moved out to a clinical trial operating account. So the big question is, how do I get one? I would like for you to go out to the School of Medicine Finance website because we have a lot of resources out there about clinical trial operating accounts. So first, to start out, we have the account request process, which entails the person that will be managing the clinical trial account and the departmental DEO would need to go out, take the test in LMS, pass, and attach those two certificates with your School of Medicine clinical operating request form. And on that operating request form, we ask you questions kind of about your clinical trial operation. So how many clinical trials are you planning to run from here? How many PIs are you going to run from here? How many research nurses are you going to run from here, to try to make an assumption before we approve your account request if you need more than one account, or if you potentially don't need a clinical trial operating account. And we've also put out there some best practices that we've come up with so far for a clinical trial operating account, and where we would like to go is to actually have a process document that details how to reconcile your clinical trial operating accounts each and every month. So to help you, somehow I'm missing a slide. There's a slide missing that tells you that we are going to have 2 educational sessions ran over in the School of Medicine. One will be on January the 15th, I think at 9 a.m. And the second one will be on January the 29th at 2 p.m. If you currently subscribe to our School of Medicine Finance newsletter, all of those training sessions and the doodle links to sign up for those sessions will be in the newsletter, along with a couple other sessions that we'll be running in February. So if you currently do not receive the School of Medicine newsletter, I'm going to ask that you send us an email to School of Medicine Finance with your contact information. And this is a newsletter that we send out bi-weekly. It has a lot of updates from financial affairs and procurement, pretty much anything that's going on in the finance arena that you would need to stay abreast of. So I feel like it's very important for you to go out, check out our website, and also to subscribe and sign up for that newsletter. Before the training will start on January the 15th, we plan to have the actual process document out there with a step-by-step reconciliation of a clinical trial operating account. So we will be reviewing clinical trial operating accounts, meaning the dean's office will come out to departments and miscellaneously just select various different accounts to review each month to make sure that you are using the recon process and using the clinical trial operating account as it's intended. Does anyone have any questions, concerns at this point?
So this document that you're talking about, the step-by-step, does that have recommendations in there as to like when you're signing up for it? Right now we're pulling everybody on all the entities for nurses for all the content. We're running into sidebars like paid time off. How do we allocate that time across? Or how do we account for that? We're like different percentages of time and things like that. So we'll have guidelines in that.
We do mention, I guess, some guidelines in there that have kind of come across our head. So if it's to the point where you have a large pool of clinical trials that are not very active. So let's say you have a group that's in long-term follow-up and you have a group that is like slowly accruing patients, that you may want to differentiate the effort that you're charging to each of those. But I will ask that since you're actually in this space and I don't manage a clinical trial operating account, will you send me an email with your concerns and we'll try to make sure that we address those in the process document. And of course, when you come to the training session, usually there's a lot of learning that goes on there, just because all of the people that are using the accounts come and pose questions, and they also share some of their practices, which may help some other departments and other users. Thank you.
Good afternoon. My name is Christian Plo. I'm from the Investigational Drug Services. I'm not going to talk about pharmacy fee structure. I think that was from the last time I spoke. But I was going to tell you another thing that I talked about last time, just kind of closing the loop, is we temporarily moved out of our space in October. I gave you guys the information at this meeting last time. And I sent out emails. It's the goal that we move back into our original space sometime in January. The space that we've been in is extremely small, and we're looking forward to moving back to our old space that's going to be fully renovated. Once we get the go-ahead and the date of when we're going to be moving back, I'll let you guys know. I'll send out an email to the group. One other thing just to make note is monitoring visits. So we've changed our monitoring visit schedule up recently. We're doing monitoring visits Monday through Thursday from 12 to 3 o'clock. So just to make note, if you have any questions with that, let me know. But also make appointments well in advance if you can. And what we've been running into recently is either monitors canceling at the last minute or them just not even showing up. If you guys know that a monitor is just not coming that day, let us know if you can, so we can get them off the books and we can reschedule it at another time. Does anyone have any questions? Yes. 1 hour. They can ask for more, but we just need to know well in advance. If they ask for more, we'll put them in a different area of the pharmacy, so they won't be disturbed. But the max, like for a traditional visit, it's 1 hour. All right, thank you.
Hi, everybody. I'm John Sandifer. I'm the OnCore team leader. I'm an application architect. And what I want to do today, this is going to be kind of information dense. So I apologize for that, but we really need your help solving some problems that we're having in OnCore. And if you would, get the slides after the presentation so that you may want to review them. But we're going to hit some high points of problem areas that we're seeing that are causing a lot of problems for you, our billing folks, and the OnCore team, as well as some of the folks in CBR. So what study visits must be managed in OnCore? And the simple answer is all of them. We've heard that some people are under the impression that they should only occur visits that have clinical billables. This is not the case. You'll want to occur all visits on a study, and this is going to be very important when you get to using OnCore financials, because all that information flows up to what we call the invoiceable items tab, and that's where you're invoicing people, or you yourself will work with those numbers. So that's very, very critical. All visits must be occurred. At the very beginning of the process, we have calendar validation, and this is an extremely important step. When OnCore Calendar Services, or OCS, notifies you to validate your calendar, pay very careful attention to the billable procedures that are going to appear on the CTB End, and make sure that these procedures occur on the correct visits and have the correct billing designations. They ask for standard of care and the X to bill the study. if you don't validate in a timely fashion, there's some downstream effects this has, primarily with the development and testing of your power plan. It takes a week maybe to get a power plan built, and then probably a couple of weeks to test. So you want that power plan ready to go before you open to accrual. So the sooner you do validation and get through those steps, the sooner you're going to get a power plan. It also can delay the ability for your budget folks, once you get to using OnCore financials, to be able to work with and complete your budget. If there are mistakes in the calendar, not validating thoroughly, if we don't catch these things, then down the road, we may have to back up and fix things. It's much harder to fix things after they happen than prior to the event itself or the error in question. So if you need information, you can contact our OnCore calendar team at OnCore Calendars, UAB, and C with questions. So what can go wrong with subject visits? And this is a big one. So when you occur a visit in OnCore that has clinical billable items, and these are things that have been through the FAP approval process and linked to the OnCore charge master by your calendar builder, when you occur that visit, a CTBN will drop, a clinical trials billing notice. Everybody know what a CTBN is, or at least you've heard of it. I'm going to get back to that in just a second. We'll talk a little bit more about it. So what we end up with is a report that some of you may have been working with Nassim Anjum from the OnCore team. Nassim has been spearheading what's called the subject visits report. Subject visit details report, actually. And if you look in your reporting menu in OnCore, most of you can see the subject visits tab. And there's only one report in it, and that's this report. And you can run it for your management group, and it'll show you what visits have been left out there as planned or marked as planned. And let's talk about what the difference is here. So if you don't take a patient off study, you just leave them out there hanging, OnCore thinks that those visits should have been occurred. So there are several reasons, and I'll talk about more in a couple of minutes, why you need to take those subjects off study if it's appropriate. So then that'll get them off this planned visits report. Or those visits just may not have been occurred in OnCore. When that happens, CTB Ends don't drop, those visits don't go through, and that's problematic too for a couple of reasons we'll talk about. Marked as planned is a little bit different. Marked as planned is if you have clicked submit on that visit, but you forgot to click the little occurred radio button that's at the top of the visit form. We don't see as many of these, but that means you plan to occur that visit, you just forgot to check that radio button. So we'll follow up with you, or you can run the report yourself and catch these things immediately. It's an important point to recognize that CTB Ends do not generate charges. They don't drop charges. Those charges are dropped either on the Cerner side or IDX or HealthQuest, one of the billing systems. CTB Ends inform the billing offices. They get these things and they go through them, and that tells them how to direct those charges. You know, when CBR goes through and does your coverage analysis, and they say this charge is a research charge and should be billed to study, this charge is should go to the patient account. That's coverage analysis. So the CTBN informs the billing office what account to put those charges in. So what happens if a CTBN doesn't drop? Those charges will be held for a while, and then generally they're going to get charged off to the patient account. I'm just speaking in generalities. If that's incorrect, those charges may be denied or they may be paid. In both cases, that's very problematic. So in visits, if a visit's still in the plan state, it may be that the subject status needs to be changed, get that patient off study, and I've got a screenshot coming up of that. Or you need to occur your visits and keep up with your visits. If visits are still marked as planned, it's very likely that the CTBN was intended to drop, but you just missed that radio button, and you can go back and fix that rather easily. Timeliness of occurring visits. I've been hearing about this since Carolyn Whitmire was here in the early 2010s. 24 to 48 hours is the standard. The billing office is only going to hold these charges so long before they release them. So you want to get your visits checked in or occurred as quickly as possible. Not to do so risks billing the patient account for a research charge, and that's not good for anyone. When research charges are billed incorrectly, we face compliance risk. If and when those charges are denied by insurance, the health system may have to take them out of the patient account and write it off. And we are writing off a great deal of money every year due to this. So what's the magnitude of the problem? Hundreds of visits were planned and never occurred over the last year, and we're working to get this number down. Hundreds more were left in the status of marked as planned. It's much more difficult to correct these problems after the visit has occurred, because then we've got to get the billing folks involved, and they've got to do transfers between accounts and often give money back. So the OnCore administrators, Lisa and Nassim, are working with the study teams to correct the problems, and the number of outstanding visits with these issues has decreased by now over half. It was half when I turned in my presentation, but as of yesterday, it's over half. So we're getting those numbers down. And a lot of it's just education, and that's one reason I'm up here today. Some of these things, same things would have appeared in the recent Trending in Trials publication that the CTS puts out. So occurring visits is vital for accurate billing. If you have an additional procedure and you need to add it to a visit and that procedure is not on the calendar, call us or email us to assist, and we'll help you select the right procedure. It's important that we get the correct procedure in these things, and we're happy to help you with those. Once again, if the correct charge master item is not added to the additional visit, it will result in a billing error that requires extra work by you and the billing office, and we'd like to avoid that if at all possible. Last couple of slides on subject status. Very important, not just for the problems with billing, but if your subject, when you register a subject to OnCore, where does that subject immediately go? It goes to impact. And that on-study indicator appears in the patient's chart in the banner bar. So if you're not registering your patients promptly, a treating physician may not see, they won't see that on-study. They won't see the billing or the research summary that Mark was talking about. They won't see the contact information from the trial. So critical information will be missing from their treatment. On the back end, if you don't take the patients off the trial in a timely fashion, they still look to be on study and they may be treated inappropriately. After 15 days, after you take them off trial, that on-study indicator will go away on its own. This was decided by a team of physicians that we talked to, and that's the length of time they figured would get study drugs out of the system, their systems and things like that. So that notice will go away on its own after 15 days. Last slide, the bar in orange, little square in orange, that's where you manage your consent, eligibility, on study, and treatment. And the follow-up tab that's shown here is where you take patients off treatment, putting an off treatment date in that box. As an example here, that'll get these patients off treatment. So any questions? This is probably a little longer than other people's, but you can call the help desk or email us at the email address here. I can probably take a couple of questions. Teresa. So you're saying there are no billable procedures? Right. If there are no billable procedures right now, those studies aren't going into OnCore. We will, after the first of the year, look at putting all studies in OnCore, where you can keep all studies in OnCore, use one system. Anyone else?
Do you have people that sign up to the issue, or we just call or email the full group?
It's better to use the email. That's a good question. Thanks for asking it. Because we have administrators that are on call, and on call rotates each week between 4 people. So if you email the email address, we're monitoring that box, and you're generally going to get a quicker response. I actually keep an eye on the box myself if I know people are in meetings and that sort of thing. So that's probably the quickest way for us to get back to you. Okay, thank you.
Good afternoon again. My name is Matt White. I'm the Director of Clinical Research Informatics, and I will talk to you about clinical data and getting clinical data to support effectively any part of your research process. Hopefully this is not new information. I've talked to you guys 2, maybe 3 times before, but we are still here. There are lots of tools and lots of services available for anyone at UAB, anyone in the research process, to provide any manner of clinical data for any part of the research process. So I tend to say that over and over again. But any part of the research process, whether it is feasibility, whether it is proposed enrollment for research studies, preliminary data for proposals, recruitment data sets, secondary analysis data sets, providing information to you for to minimize manual chart review so that you don't have to go patient by patient and copy labs from one place to another. There are opportunities for you to have lots and lots of clinical data effectively anytime you need it for research purposes. And what we have done is build self-service tools that you can do a lot of that work yourself, and have a group of very nice people whose job it is all day, every day to provide people data for research. So the primary way to interact is I2B2. If you Google I2B2 UAB, you can't miss us. You can log in anytime, day or night, including if your grant proposal is due for submission to OSP the next morning. You can still log into I2B2 and count yourself 2 or 3 populations of interest and get preliminary data for your submission. It allows you to construct queries to count the number of patients within UAB based on clinical characteristics, visits, demographics, encounters, lab values, medications, allergies, lots and lots of data. You can count those patients, determine a population of interest. You can determine 2 or 3 populations of interest and compare them. You can download lots of HIPAA-limited data set data, more or less de-identified data at any time without having to pick up the phone and call anyone. It doesn't include medical record number and encounter, so you can't actually contact a patient, but you can download every lab test for a population, every visit, every medication, et cetera, so that you can do more detailed feasibility assessment, or in some cases do preliminary data and parts of your research. If I2B2 doesn't meet your needs, or at the point where you need identifiable data to recruit patients, just submit a request to the EDW team, and we can take your population and provide you all the contact information, every visit, including future visits, so you know where they're going to be. And that includes custom analysis for anything that exists in the EHR. So if you can point to it in the clinical record and ask a logical question, we can provide an answer. This is a snapshot of the current content, about 1.4 billion observations, a little over 1 million patients. I think we have about 700,000 unique clinical variables that are included in I2B2, so you can ask lots of questions. A few updates, so this is a little bit different information. Some of the things that we have added in 2019, some things related to geographic related data, minority and health disparities research, Things like the area deprivation index, a good deal of census data. If you're familiar with the census categories, those 4 sections include quite a bit of the relevant census information. And then a few special populations defined for targeting populations of special interest, special needs, particularly for proposals with specific interest in social determinants of health. We have incorporated patient-reported outcomes information in coordination with infectious disease. So if you are one of the clinics that is either using that information, it's now available in I2B2 for you, or if you're interested in those patient-reported outcomes, and that is a variety of standardized instruments as well as custom PRO data. We have had for some time biospecimen data, but one thing of note that the tissue collection and banking facilities data is now tied with medical record number to the rest of the clinical data. So you can identify patients based on clinical characteristics as well as the existence of specimens, physical specimens in the tissue collection and banking facility, if you are interested in specimen-dependent research. That is in addition to what has been the case for quite some time with the SPAN biorepository and the biospecimen management module in OnCore. That information is incorporated as well. The Alabama Genomic Health Initiative, one of the things that it is intended to do is encourage future research on that population. It is about 5,000 people who have mostly genotyping, but in some cases whole genome sequence, and there is data from OnCore for family history. There is genomic data, so you can identify populations of patients that include clinical characteristics as well as having had genotyping or even having specific variants in specific places from that population for future research. Another update is we are now live on the Accrual to Clinical Trials Network. It is similar in structure to I2B2 in that it is a user interface that you can log into, construct queries yourself, and count patient populations. What's different is that it is not just UAB data. It is 40 sites around the country. It is part of the NIH NCAT CTSA program. So it is effectively 40 of the top research institutions around the country. So similar to I2B2, you can go find patients based on demographics, encounters, labs, meds, diagnoses. You can't do it on the breadth of the data that you can locally within I2B2, but you can get counts of patients from across the country. Where this is valuable is if you are interested in multi-institutional research, if you are doing a proposal for that will span beyond UAB, you can count patients and identify populations of interest for feasibility and for grant proposal that specifically says these 10 institutions have these populations of interest. And we have contact information, and that can lead to other services within the CCTS for promoting multi-institutional collaboration as well. If you're interested in doing that, just email i2b2support@uabmc.edu. If you Google I2B2 UAB, you will also get information about the ACT network and links to log in. And if you have any information, let us know and we can provide you access. There's our support information. If you have any trouble, by all means, just reach out to the CCTS Research Commons as well, I2B2 support, or me, though I would go to those other folks first. Any questions? Yes.
So with your biorepository or biospecimen data that's not anonymous anymore, we have IRB approval for a waiver to find biospecimens. There's someone who can look at that for you without getting the personal information to find the biospecimen.
So specifically for the tissue collection and banking facility, you can identify a population of interest based on the existence of biospecimens. to get the physical specimens, we hand you off to the TCBF staff. If you want additional information about them, we may have a little bit, but more or less we've included in I2B2 all of the relevant specimen information. Once you go to actually incorporating those specimens into your protocol, that's a handoff to the TCBF staff. Any other questions? Okay, thank you.
We have one more presentation and then we're tight on time.
All right, last one, y'all. Okay. So what I'm going to be talking about, I'm going to be talking from the perspective of OnCore and just timeliness in relation to your specimen processing. So John, he established the importance of the financial aspects about using OnCore correctly and in a timely manner. But I'm going to discuss it from a specimen processing perspective. All right, so number one thing is it is imperative that you get your patients into OnCore prior to delivering a specimen to our lab or any other lab that you're using, especially if you're an enterprise study or a cancer center study. The reason why this is really important is that in order to assign your specimens and store your specimens, we need to have identifiers on your specimen, and we need to be able to make labels for you. So just for the purpose of just having everything linked to your participant or your patient, it needs to be entered into OnCore prior to us receiving the sample. If you are using the OnCore calendar, which most of you should, it is also important that we have an accurate and correct calendar released, and that we are notified of when this calendar is released. Again, like John mentioned, that this is going to help us understand the collection configuration for your specimens. So that way for each visit that your patient or participant may have, we can have an accurate understanding of what specimens need to be processed, how they need to be processed, and just making sure it matches to your visit details. So just let us know when your updated calendar has been released or it's been entered into OnCore, so that way we can double check and preview the calendar to help with our specimen processing. Another big point is that it's really important to communicate with us. We would love to help you, and a part of that requires talking with us. So if there's anything you're unsure about, or is there a question, we will be happy to answer it or help you find the answer for it. On top of that, we need to know if there's any changes or updates to your protocol. We need to know if you've alerted the pertinent personnel. So if you let research nurses know, have you let other coordinators know, if you let the lab managers know, if there's any new details for your protocol, you need to let us know. Another major piece of information that we need to know is changes to your laboratory manual. So if there's any changes in your processing procedure, i.e. processing time, centrifuge times, anything like that, please let us know. It's also very important that you update OnCore with a revised study manual. If you go into your console, there's different documents that you need to keep update for. So one important one is the laboratory manual, so that we can consult with that to make sure that we're processing everything to your study's instructions. And also, please let us know if you have any new study personnel. If anything were to happen, or if we need to ask questions, we need to know who we're gonna have to talk to. So it's also important to go into OnCore and update who's your study coordinator, who's your program manager, who else needs to be informed in case certain things happen. All right, we've also been having an issue with specimen delivery and arrival. So I just want to establish that your lab results, your research results, are only as good as the condition of your specimens. So proper and timely handling and processing of your samples facilitates quality specimen management, which will help you with accurate testing and data. So specimen processing is dependent on a completed and released OnCore calendar configuration, preparation of specimen kits and labels that accurately reflect your visit details, and then prompt specimen delivery and handling. You would be surprised the amount of people who will show up outside of their study window. If your window is an hour for processing and you're showing up 3 hours later, what do you expect us to do? So I'm sorry, like it's just, what do you expect us to do? So we'll do it, we'll process it for you, don't worry about that. But what happens to your specimen? What happens to the accuracy of your data? It needs to it needs to happen. So we just ask you to just make sure that the OnCore calendar is configured correctly. It's reflecting your visit detail. Please let us know if any changes occur. Let us know ahead of time before patients come in. If things need to be adjusted, if things need to be printed out for you, we will be happy to do that. If you have any more questions, I have listed the lab managers for the CCTS specifically. So Maitland and Jing will be happy to help you with anything related to specimen processing. If you have any other questions, like bigger questions about using specimens, you can definitely contact our director, Dr. Edberg. And then you can also contact or see our website just to see more information about how to set up your study for specimen collection and what you need and materials that you need to get started. Any questions for me? No? Awesome. Thank you, guys.
Thank y'all again. Our next Lunch and Learn will be in April the 14th. We will send out reminders. 2020 is going to be a great year. Thank you to all our speakers, and we will see you next year.